Thank you for joining us for another Learning with National Leaders virtual event presented by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. I'm Angie Whitinger, filling in as your host for the evening. We chose to center tonight's discussion around colorectal cancer in honor of March being National Colorectal Cancer Awareness Month. We'll be focusing on treatments, the importance of screening, and some critical efforts men and women can make when it comes to prevention. I want to start with some important statistics when it comes to colorectal cancer. This first one is very important. In 2021, the recommended age for colorectal cancer screening was lowered from 50 to 45. Excluding skin cancers, colorectal cancer is the third most common cancer in both men and women. In 2019, 20% of colorectal cancers diagnosed were in people under the age of 55. 55% of colorectal cancers are attributable to lifestyle factors, and African Americans are 20% more likely to be diagnosed with colorectal cancer and 40% more likely to die from it. Now, before we introduce our panelists, we want to give you a very unique perspective of the colon and why screening is so vital to your colorectal health. Earlier this afternoon, Siteman colorectal surgeon Radhika Smith recorded this video to help us get a better understanding of the human colon.
So welcome to the inside of the colon. I think so many people don't really understand exactly what is a colonoscopy and what are we doing when we're looking at the inside of the colon lining. So here we have this giant inflatable colon to try to make that a little bit more clear. And I'm going to take you on a tour of it. So firstly, we have normal colon tissue. The normal colon tissue that we see is pink, it's healthy, there are no abnormal growths or anything that's concerning, and this is what keeps you having those nice functioning bowel movements. The next step is going to be what's called a polyp. Polyps are very tiny precancerous growths that can be removed at the time of your colonoscopy. So what makes colon cancer so different is that it's very preventable. When we are doing a colonoscopy, at the time of the procedure, not only are we able to diagnose cancer, but we're also able to prevent it by fully removing these polyps and then not having any cancer grow in its place. Coming over here, we have what's called a malignant polyp. Now this is an early polyp that has grown to the point where it does have focuses of cancer in it. Sometimes this can be treated with colonoscopy alone, but more often than not, it will require surgery to completely treat the cancer and many times cure it. Now we're going to head over to advanced colon cancer. While advanced colon cancer isn't something that can be managed at the time of the colonoscopy, we will take biopsies and allow you to get that diagnosis as quickly as possible and then start that conversation of how do we get you treated and cured. Generally speaking, the time that you're having the colonoscopy is painless. It's easy. The prep is the worst part for sure, but for the most part, once you're done, and it just makes it so it underscores why it's so important for you to get that screening colonoscopy and talk to your doctor if you develop any new or concerning symptoms related to your bowel function.
Dr. Smith, thank you so much for that information. I'm a visual learner, so that was very helpful to see that full scale.
You're welcome.
And well, it's hard to watch yourself sometimes, but you did fabulous. It was a good show and tell there. And thank you for being part of our panel tonight.
Absolutely. Thank you for having us.
We have some other people joining you here, your colleagues, our other Washington University experts at Siteman Cancer Center, our radiation oncologist, Hyun Kim. Thank you for being with us.
Thanks for the invitation.
Absolutely. Colorectal surgeon physician assistant Shanna Zwick.
Yes. Hi.
Thank you.
Thank you.
And medical oncologist Katrina Pedersen.
Thanks for having me.
Absolutely. Thank you. We're going to have a really interesting conversation this evening because it's very important information. And just in talking with you beforehand, you guys are very good at teaching this to people on a level that we can all understand. So I appreciate that. We want to remind our viewers to submit your questions right here on this website, and we'll try to get to those answers for you throughout the evening. So go ahead and start submitting those, and we'll get those to the doctors here. Let's start with you, Dr. Pedersen. When we say colorectal cancer, what are we talking about?
Right. So that is a cancer that arises in a part of our a part of our body called the colon and the rectum, or the large bowel or large intestine. And so really, if you think of the Riddler from Batman and how he used to have a question mark, you know, kind of on his belly there, on his costume, that's pretty much the track that our colon follows, from right, up, over, down, and then it ends in the rectum and goes to the exit. And so any cancer along there is a colorectal cancer.
Okay. At the beginning, we mentioned some statistics, and we said that African Americans are 20% more likely to be diagnosed with colorectal cancer. Why is that?
That's a great question. And a lot of the times when we're asked, you know, why do certain groups have a higher risk, there are a lot of things we don't understand yet, and that's an area of heavy research. So in African Americans, for instance, there's a large project that's underway at Washington University, and in cooperation with a number of other major institutions across the country, called the Colorectal project, that is looking at that, trying to really figure out on a large population basis, why do African Americans get this more often, and why are they more likely to die from it? Some things that have been floated are if patients are of, you know, lower socioeconomic status, or if you don't have as good of access to health care, if you live in an area where there just aren't as many providers who can do colonoscopies, or even primary care doctors who can teach and recommend colonoscopies, that you're going to run into more advanced disease and have greater problems.
I see. We mentioned too that there are some factors that can lead to your increased chances of getting colorectal cancers. Can you talk about the leading causes of them?
Yes, and I'm sure a lot of folks here too can chime in at any point. What I tend to see most often when we can attribute it to any cause, or there is a group, though it is relatively small, for people who inherit a higher probability of getting it. The most common familial syndrome, one that can be passed from generation to generation, is called Lynch syndrome. And while it's not common, it is common enough that everyone really should, if they have cancer on a biopsy from a colonoscopy, that should be tested, you know, in that sample or at the time that cancer is cut out. However, the vast majority of us, it's really coming down to choices that we make in our lives, or just factors that we can't change. So of the things that we can't change, you know, while it is rising in younger people, older people are still more likely to get colon and rectal cancer, and that's why, you know, screening doesn't start at birth. That's why colonoscopies start at the age now of 45, because that's where the risk really starts rising. Being male, you're slightly more likely to get colorectal cancer if you're male compared to female. If you have a history of an inflammatory bowel disease, like ulcerative colitis or Crohn's disease, that kind of chronic damage from those diseases can make it more likely to have cells turn into cancer. And then of the things that we do have some control over, being more physically active, you know, I think that for a lot of us, we're tied to our computers and our jobs and don't get out as often, get our heart pumping harder. And that's a problem, and that's a problem across many cancers, not just colorectal cancer. Not eating enough fiber, drinking alcohol, smoking. I mean, there are themes of things that can impair our immune system's ability to get rid of cancer cells right when they begin.
Right. Those things shouldn't be that surprising, because we hear it time and again for our health, don't we?
Yeah.
Yeah. Let's turn now to Shanna Zwick. Let's talk a little bit about some of the symptoms for colorectal cancer.
Yes, absolutely. I would say pain, bleeding, any sort of change in your bowel habits that's from your baseline or diameter of your stool. Weight loss that you can't explain, unexplained fatigue, I would say, are some of the most common that I would see.
Important to pay attention to those.
Yes, definitely.
And approach your doctor if you have those
Absolutely.
issues.
Anything that's a change from the baseline or anything that you're concerned about should always just be evaluated.
And then what if someone has these symptoms, we just talked about making an appointment. When we're talking about baseline, I mean, is it like, what's the difference between just something that's normal and something that should be checked out? You know, like there's
I would say, you know, things that are persistent or they kind of can't be explained by other things. The one that always comes to mind for me in my practice is hemorrhoids and hemorrhoidal bleeding. A lot of things are explained away a lot of the times as, oh, that's just your hemorrhoids. And I think if there's something that's persistent, it should be looked at no matter what your age is.
Okay. Okay, so persistent.
Yep.
Okay. Screening, of course, is an important part of diagnosing cancer sooner when it's more treatable. Dr. Smith, what are the screening guidelines, and can you tell us, they just changed. We were talked about going from 50 to 45. Why? Why did that change?
That's right. I think as Dr. Pedersen mentioned, and I think we'll probably touch on, the rate of younger people developing colorectal cancer has increased, and in response, the government has now decreased the recommended guidelines to age 45. So the most important thing when you're thinking about screening and your own personal health is knowing your family history, and that's both a family history of diseases like Lynch syndrome or colitis or Crohn's disease. Those things can potentially present in you, so it's important to know those risk factors. And then also any history of polyps or any history of colorectal cancer, particularly in a first-degree relative. So that would be a sister, a brother, a child, unfortunately, which is a new thing that people aren't really thinking about. That, you know, typically it used to be your parents have cancer, and so that impacts your screening. But now we're even seeing, you know, my kid has cancer, and now I have to get my colonoscopy more frequently because the age of 20s and 30-year-olds are actually increasing. But generally speaking, in an asymptomatic individual, meaning none of those things that Shanna just so clearly laid out, should start their colonoscopies at age 45, and they can go every 10 years if they don't have any significant family history and if no polyps are found. If you have a family history, we typically want to start screening 10 years before the age of diagnosis of the relative. Okay. So if a family member or your parent had colorectal cancer at age 55, then you would still do 45. If it's at age 45, you would start at 35.
Got it. Can you talk at all about, I mean, you said you were seeing it in younger people. Do we know why?
So, you know, there are a lot of theories. I think that, you know, again, as she had mentioned earlier with some of the increased risk of obesity that we're experiencing, you know, and processed foods, the way that we change our diets and environmental exposures over time can increase our risk. But there is a lot of research going into really trying to clarify what exactly is causing this.
Yeah.
But, you know, it's not super surprising to see all of the new data that's coming out, but it still is very concerning.
Interesting. Well, we talked about the screening tests that are available, and you spoke about that in the video, but what exactly are you looking for?
So during a screening colonoscopy, it's important that, you know, the bowel prep is really good in order for us to have a good examination. And
so there's a reason for doing
that's exactly
the prep,
right.
even though it's not fun, it's important.
That's correct. So we go all the way around to the tip of the question mark or to the right side of the colon, and then we slowly back it out, and we're looking for polyps or for masses. Polyps, oftentimes, as mentioned in the video, can be removed at the time of the colonoscopy. They can be biopsied and then recommended for surgery if they're too large. And then cancers will be biopsied and then also recommended for surgery to be removed.
We spoke a little bit earlier that, I mean, by removing those polyps, I mean, that is taking out any, if you have these screenings, you're removing your risk of cancer. Is that accurate?
That's absolutely accurate, and we're actually seeing the benefit of screening colonoscopy over the last, you know, the 90s and 2000s. There was a big push to increase the amount of screening colonoscopy that was being done in age-appropriate individuals, and there's been a huge benefit. So people over the age of 55 are seeing a decline of about 1 to 2% over time per year, whereas our younger patient population who isn't in this catchment of screening are not seeing that same benefit and are paradoxically seeing a large rise.
So when you catch it at the polyp stage, that's a good, because you can get rid of it.
That's exactly right.
Yeah.
And it can't create a problem for you.
There you go. That's where the screening comes in, for sure. And why, you know, we talk about it every 10 years, and that seems like a long time, but why that long space of time? Why 10 years?
So we typically know that colorectal cancer is quite slow growing. Unlike other cancers, it, for the most part, when it's in that polyp stage, it takes typically about 10 years to develop into something more concerning. Once it starts, of course, it's a different situation, and we would hope that the patients would have symptoms, and if they had symptoms, even if you had a colonoscopy a year ago, again, you should have a conversation with your physician. But because it is, generally speaking, a slow-growing cancer, and that process from going from a polyp to a cancer, so not cancer growth in general, but that transition, that transformation of polyp to cancer, typically is 10 years. So that's why we say if you're good at 10 years, you have no polyps, and you can come back in 10 years.
Yeah, listen to your body.
Correct.
In that time, but yeah, 10 years. That's interesting. Dr. Kim, we're going to get to you. I have some questions for you, but we have some viewer questions. So let's take those real fast. The first one is, what differentiates a colonoscopy being preventative versus diagnostic? Who wants to take that one?
I'm happy to.
Go for it.
The one doing the colonoscopy.
You're on a roll. Go for it.
Really, honestly, this is going to be a differentiator for an insurance company. So a preventative colonoscopy is a colonoscopy in a patient who has no symptoms. So that, or they're not doing a surveillance colonoscopy. So for example, they had a really large polyp 5 years ago that was removed, and then they're due for their colonoscopy. That would still be considered screening or surveillance. That's the other term that we use. Diagnostic colonoscopy is only used for a specific indication. So if you have abdominal pain, if you're having constipation, if you're having diarrhea, if you're having blood in the stool, or any of those alarm symptoms, then it's really a coding tool that we use to say this is a diagnostic colonoscopy.
Okay.
But it's the exact same procedure.
Yeah, nothing changes when you're in there necessarily.
Yes, unlike a mammogram, I believe those are separate studies, whereas in a colonoscopy, it's the exact same thing.
Interesting. Okay.
Unfortunately, not all insurances will cover screening colonoscopies. Whereas they're more likely to pay. In my experience, you would know better. You both, whether.
Yeah, typically, I think you're right. The diagnostic, it's a little bit, there's more of a charge.
There's no national law saying that insurances have to cover screening colonoscopies, even though they're recommended. And so that can unfortunately be a barrier.
Yeah.
And they sometimes make their own policy of still keeping it 50 versus 45. Or
Okay. Wow, interesting. While we're on this, let's just go ahead and answer these questions too. Is the at-home FIT test just as accurate as a colonoscopy? That's interesting. I've had some friends that have chosen that route. Does it talk a little bit about the difference there?
So there's the benefit of FIT being something that you can do in the privacy of your own home. It's uncomfortable for a lot of people to think about anything associated with their bowel movements. And it does have a surprising accuracy over, when put in context with a flexible sigmoidoscopy, it's pretty good for a fecal occult blood test or a FIT test. Yeah. That said, the big drawback is that you don't have the benefit of detecting tiny lesions, number one, and tiny polyps. And number two, you can't remove them. So they might say the FIT is positive, and then you will need to go down for a colonoscopy. But I think it's a good option for somebody who doesn't really have isn't really appropriate to undergo anesthesia or, is a little bit of a higher risk for having an elective procedure. And then we can say, okay, if I'm gonna go through the prep and I'm gonna go through the anesthesia, well, no, and then I know that we have a higher degree of suspicion.
Right. FIT, Cologuard, is there any difference between the two? That's the same?
They're all fecal DNA tests, and then the fecal occult blood is a little bit different than that.
Okay. And same thing as what you said. They're same results.
It's the same issues that you just have to put in a context that you can't actually remove the polyp at the same time.
Right. One last one before we come back to you, Dr. Kim, and is genomic testing available?
So I'll take this. Yes. Now I have a feel there are
yes, but
a lot of different tests right now. So in the context of where we're at in our conversation, like, screening and early detection, there's not really been any genomic blood tests that can detect cancer from the blood, not directly. Though there are some that have been in development that have been tested. There are some that are being marketed to people, although it's really unclear still exactly, what the value of them is, how accurate they are. I mean, there's still a lot of data that we need to learn about how well they're functioning. So I'm not going to list the names of any of them, that are used for just a blood cancer test, but they're at the door, they're knocking, and I think in a few years we're going to be having a different conversation about that.
Interesting. So for the time being, I mean, screening is still the number way. Okay.
Yeah.
Good. Okay, so Dr. Kim, we're going to come back to you now. Thanks for letting us pause for those. The American Cancer Society recently came out with a staggering report about higher incidence of rates in colorectal cancer, as we talked with Dr. Smith. I mean, can you touch on a little bit more about why this is happening? We touched on it just a bit, but can you shed any more light on that?
Yeah, so I mean, basically what we're finding is that the young onset population, the incidence is rising about 2 to 4% in some countries, and we're not sure why. The adult incidence, or the later onset colorectal, doesn't seem to be rising as quickly, and that may be because we're doing a good job screening. People are more open about talking about their disease and seeking medical attention, maybe even having insurance and the ability to go seek medical care. Why is this happening? Dr. Smith touched on this a little bit, and it's difficult to say. There's been large epidemiological studies, retrospective studies. We kind of feel that it has to do with sedentary lifestyle, processed meat, red meat. It may be related to high sugar drinks or obesity in adolescence and early adulthood. But I think the jury is still out. I think it's a lot of factors. There may be some genetic predispositions that Dr. Pedersen talked about, but we're still trying to figure it out.
Yeah, it'd be interesting to watch. Healthy lifestyle is always the way to go, it seems like.
Absolutely.
Healthy diet, no smoking, no drinking, those sort of things, for sure. What particular challenges do young adults face with a colorectal cancer diagnosis?
Yeah, I think with any kind of oncologic diagnosis or cancer diagnosis in young people, first, I mean, all of us here are fairly young. I mean, at this age, we think we're invincible and it couldn't happen to me, right? And so we tend to push off the symptoms, and because of that, they're frequently diagnosed a little bit later than later onset colorectal cancer patients. There's also the socioeconomic factors. Some of them may not have stable jobs. Some of them may not be able to take off time from work or for their young family that they have to take care of. And there's the stigma as well, I think nobody ever wants a stoma, even though our talented surgeons are very good at taking care of our patients. But, it's different thinking about a stoma or a permanent ostomy in a 70-year-old versus somebody who's 25 and still has, the whole life ahead of them.
Yeah, definitely. Now you are involved with, you're leading Siteman's new young adult colorectal cancer program.
Yes, we all are.
All are,
yeah.
Okay. Can you talk a little bit about this new program and especially since this is a rising topic?
Absolutely. So, yeah, we were fortunate to work with Siteman's leadership to form this young onset or early onset adult colorectal program. And what it is, it's focused on kind of the whole patient. We understand that there's unique socioeconomic circumstances and considerations like fertility preservation, sexual health, psychosocial, financial, genetic counseling. And so what we do is not only do we take care of the cancer, we have a specific tumor board that addresses each of these patients. We have excellent providers such as Shanna, as well as some of our other team who are looking out for these patients as they come into Siteman so that we can route them to the necessary ancillary services as well. And so they see these people who can help them in the holistic care, and then we make sure that we take care of them as best as possible.
Yeah. Shanna, can you tell us a little bit more about the resources
Absolutely.
that are available?
Yep. So as Dr. Kim was saying, we have kind of a multidisciplinary approach where we have surgical and medical oncologists and radiation oncologists, as well as our pathologists and our radiologists kind of all review all of these patients and really kind of hone in. And we're focusing not only just for colorectal cancer in general, but really for this group, we're trying to focus in the under 50. And some of the resources we have include the Living Well Center, which has kind of of focusing on that whole body wellness, like he was saying, and they have social work services, they have dietitians, nutritionists, they have massage, acupuncture, kind of really a lot of different resources. And then our genetic counseling as well is another big component of it, making sure, because since this is happening younger and younger, and if there is any sort of family history or anything like that, kind of really honing in and making sure that the patient is taken care of.
Very good. Dr. Pedersen, if a person is diagnosed with colorectal cancer, what are the treatment options?
Yeah, so the treatments that we use are really specific to two things. One is what stage the cancer is at when it's diagnosed. So colon and rectal cancer has 4 stages, like many cancers do. And 1, 2, and 3 are potentially curable. Some 4s are, most 4s are unfortunately not, whether it's in the colon or rectum. And for the early stage disease, the treatment is actually quite different. And so for colon cancer, the vast majority of those folks will go right away to surgery, have that cancer removed, and then a few weeks later, depending on, what we saw under the microscope about how much the cancer cells were invading through the wall of the intestine there and how many lymph nodes may or may not have been involved when the surgeons took those out along with it. That'll determine whether or not someone needs chemotherapy. And if they do, that will be for a period of about 3 or 6 months, and then hopefully they're cured. And the majority of people, at stage 1, 2, and 3 will be cured, fortunately. With rectal cancer, that's where, all of us get to be involved in the care of the patient. Some more than others. It's becoming much more, precise and patient-specific about exactly what types of treatments people need. But if the tumor has invaded a little bit more through the rectal wall, or if there are more lymph nodes there, then oftentimes they'll go to Hyun and get radiation. And one thing that I think is great about WashU from my chemo perspective is that the radiation oncology department has really been leading the way in short course treatment. Meaning instead of 5.5 weeks of radiation with a little bit of chemo, it's condensed down to 1 week. And really kind of going through it more quickly, getting over the side effects more quickly. And then they'll come see me and we'll give them chemotherapy. And then at the end of that, they may or may not need surgery. Unfortunately, if it looks like it's a stage 4 cancer, whether it's from the colon or the rectum that can't be cured, the same types of drugs will work for either, and then we try to treat it like a chronic disease where, we try to control it, help you live with the cancer for as long as possible. Newer treatments include like targeted drugs for stage 4 cancers, or immunotherapy. Unfortunately, it's a small group, but it works very well for that small group, and so we do a lot of research at Siteman and WashU trying to improve, the treatments that we do have, how well they work, and how many people they can work for.
Yeah, so you touched on this a little bit, but what is the long-term, outlook on treatment and lifespan if you catch growths before they turn cancerous?
Right, so I will never see those people, and that's what I want. I want
Right.
to be put out of business, like job insecurity is what I think we're all going for here. And you'll live a normal life. You've cut out the cancer before it became cancer, and it's so rare that we have the opportunity to do that. And that's, I think, one thing that is so important about colon and rectal cancers. Just get it out before it even becomes cancer and becomes a problem. Get that polyp out.
Yeah.
Once it has, gone to the tumor stage, it all depends on what stage you're at. And really the driving factor is whether it comes back in the future or whether it spreads to other organs.
I see.
So.
And I think we talked earlier about finding those polyps. It's not abnormal to find a polyp, it sounds like. You have that a lot, but you catch it early and it's a success story.
Absolutely.
Yeah. We have a couple more questions. Let's take one of those. Our family meets the parameters for Lynch syndrome, but the genetic tests do not include any in the research currently done. options. Can any of you address that? Did I read it correctly?
You read it correctly. I'm not sure I completely understand the wording.
So I think generally speaking, this might touch on the fact that we actually recommend that genetic testing be repeated. I think it's every 10 years. Definitely talk to a genetic counselor after that, just because that is true that every day we are finding more genes and more things that we can potentially target and treat that are involved in the treatment of colorectal cancer. So if the case of this questioner, if the thing that they're asking is that maybe they have a risk for a genetic syndrome, but they haven't actually targeted it, then yes, you might want to, if it might not be Lynch syndrome, but it might be something else, and then you might want to repeat your genetic testing, again, once a decade.
Like Bethesda criteria, perhaps.
Very good.
Oh.
Good. Let's take this other one. Is next generation sequencing helpful for someone with stage 3 colon cancer?
So I am biased completely.
Explain that.
Yeah, I will. I won't just leave it hanging there and say yes. I absolutely do. But we don't really have any genomic guided therapies right now that have been tested and successful and are approved for genomic subtypes in stage 3, outside of testing for Lynch. So technically it's no, and the national standard of care is that for people with early stage cancer, and NGS or next generation sequencing is not indicated. For stage 4, absolutely, it is indicated. There are certain treatments for people who have certain mutations, and basically these mutations are in genes that are kind of like brakes and accelerators. So the DNA gets changed in a way that will either, put the pedal to the metal on one of these accelerator genes or cut the brakes on one of the brake genes. And so if we can know what is really driving that cancer car, so to speak, then we can design a treatment regimen specific to that that might be more effective for those people.
Interesting.
Now, do I think that this is going to change for early stage disease? Absolutely. There is an area where we do use next generation sequencing in especially stage 2 and 3 disease. Again, this is not the national standard of care. It's not part of our guidelines yet. We do need a little bit more proof on, how we should be using it, what is the value of this test. But it's doing sequencing to very, very minute levels to find tiny fragments of DNA from tumors in the blood. We can actually figure out what DNA is from cancer and what's from our normal cells.
You're talking about the genomic testing. That's how it's done.
Yeah.
Interesting.
And so with this special testing, where we're looking for minimal residual disease, or MRD, we're using circulating tumor DNA. Another term for that, that people have thrown around is a liquid biopsy. And we can use that to help really define who is more likely to have that early stage cancer come back. And we're able to detect it earlier. Now we need to figure out, can we treat it and make a difference and maybe get more people back to the cure side of the line.
And you said this is all done just through blood work?
Yeah, a few tubes of blood.
Wow. That's incredible.
It is.
This has all come about in the last...
A few years. For instance, that testing, I think, from the companies who have developed and validated those tests, I've been using them clinically for about 3 years on the majority of my patients. It's completely optional. They are cleared by the FDA, but again, they're not part of the guidelines because we're not exactly sure if, they make a difference in curing people or not.
Well, this is great because we were getting ready to talk to Dr. Kim here about, advancements in what we've seen. Obviously, this is an advancement. What are some of the other treatment options that have improved that you've seen over the years?
Sure. So from a broad perspective, I think some of the surgical techniques with minimally invasive surgery, Dr. Smith could speak to. Sometimes for rectal cancer, they can do a transanal approach to decrease kind of healing time and morbidity. I treat a lot of rectal cancer, and so with rectal cancer, one of the exciting things on the horizon is non-operative management. And so, surgery has been such a mainstay of curative intent for rectal cancer for decades. And now with our total neoadjuvant therapy, or giving all the radiation and chemotherapy up front, we can see the cancer go away 50% of the time and patients not needing surgery, or even significantly downstaging the tumor so that maybe they were going to have a permanent ostomy, but now they don't. Some of the things that Dr. Pedersen touched on, like the liquid biopsy to detect early recurrence, or if there's any disease left, even though we can't see it on MRI or we can't feel it with our finger, that's very promising as well. And then, as she also mentioned, the immune therapy. It's for a small subset of patients, but perhaps as we identify different targetable agents in these different tumors, perhaps more and more patients will be able to be treated without radiation and without surgery, which would be fantastic. I think Dr. Smith and I would both be happy about that, right, Shanna, as well? So.
I mean, it sounds like you're very hopeful for all these things that are on the horizon.
Yeah, I think so. I think a lot of the times research is very incremental and stepwise, but sometimes something happens that surprises everyone, and then people run with it. And we have a lot of great collaboration at Siteman and Washington University, combining the sciences with the clinical to be able to look at these avenues.
Is there any other recent research that you'd like to kind of touch on that you're excited about?
I think that's about it. I mean, obviously, we're always supportive of our own clinical trials. Right now, we're participating in a multi-institution, non-operative management trial evaluating short-course radiation. So, as Dr. Pedersen mentioned, we've kind of condensed 5.5 weeks of radiation into 5 days. This has been used in Europe and for many, many years, and from the 1970s at WashU. And what we're seeing is, can we really substitute this 5 days, do non-operative management, and still have great clinical outcomes in these patients and have the cancer not come back? And Washington University is the lead institution for this multi-institution trial, so we're excited about these results.
Yeah. We have some more viewer questions, so let's take one of those. Do you have a number or website to schedule a consultation? I think we might be putting that up, or do you want to share one?
Yeah, I have the phone number for colorectal surgery, which is 314-454-7177.
Say that one more time for us, Shanna.
314-454-7177.
Very good.
And we're all on the Siteman directory and the Washington University directory.
Very good. Okay, let's see. How do you feel about liquid biopsies? Have you found this to be a useful tool? What is a liquid biopsy?
So that's like that tumor DNA
Okay.
that we were discussing
Blood.
earlier. And
Blood?
Yes, in the blood. Sorry, thank you.
No, it's okay.
So yeah, a few tubes of blood, and then we do DNA sequencing. And sometimes we're just looking for the presence of minute amounts of cancer. So other times, we're not, looking for small amounts, but we are looking specifically at what gene mutations might be. So my short answer should have just been yes.
Yeah. For all the reasons we've talked about. Good,
Exactly.
good. What mutations indicate disease that is likely to return? Are we talking RAS mutations or other APC, TP53? I don't know what I'm saying.
We have professionals in the audience.
Yes, because those are, yes.
Very educated folks. So yes, now I will say again, genomic testing is not the standard of care necessarily for early stage disease. However, we do have data for that to some degree. And it appears that, for instance, patients who have a mutation in a gene called BRAF may be more likely to have their cancer return. We also know that for those Lynch syndrome folks, so these are the people who are more likely to develop cancers because they've inherited basically a bad gene editor, so they can't fix any mistakes. And what we find for them is that they're actually, once it's cut out, if it's cut out at an early enough stage, they're less likely to have their cancer return. They mentioned APC. That is a pretty early mutation in the majority of cancers. That's even, a polyp driver, so from the earliest stage. So it's pretty common to have APC mutations. TP53, I've seen some data either way. That's one of the brakes, in the cancer car, so to speak. And so if you cut that out, then, the accelerators can kind of go unopposed. And it doesn't seem that there's a much greater risk, if any, of the cancer returning specific to that mutation.
Okay. Shanna, we want to talk to you about prevention. What are some of the preventative things people can do for colorectal cancer?
We've touched on a lot of them already, but I think, and you hit on it too, just overall kind of healthy lifestyle modifications. So high fiber diet, active lifestyles, not being a slug on the couch as we all can be sometimes, including myself. Decreasing different types of things in your diet like red meats and cured meats and processed foods, alcohol, tobacco are all things that can kind of help prevent the risk.
We've talked about the importance of screenings, obviously, but especially when it comes to those screenings, and a lot of times, are there no symptoms?
The majority of the time,
Really?
I would say that there are no symptoms. And that's why it's so important to have the screening colonoscopy, and why everybody here in kind of the specialty is so excited that we got 5 years earlier for a screening colonoscopy. Polyps can be benign, they can be benign precancerous, or they can be a polyp that has cancer in it. And so when you have a polyp kind of higher up in the question mark in the colon, then you're not really going to have a lot of symptoms a lot of the times. You won't have that bleeding. And I find that to be the exception, sometimes with rectal cancers. That's where I feel like you're more symptomatic. You have kind of the urgency, the change in your bowel habits, the bleeding, and that could even be from a small rectal cancer. But a polyp over on the right side of your colon often has no symptoms, and it could have cancer in it.
So go get the screening. That's where those, we can't say it enough during this conversation.
I think it's also worth mentioning that, while for folks less than 50, the likelihood of getting cancer is going up, and screening colonoscopies are not indicated before 45. However, we are seeing that rectal and left-sided cancers are more likely in the young population. So, the one good thing, if there's any good thing about anyone, and especially young people getting cancer, is that at least they're more likely to be symptomatic, so don't ignore the symptoms.
Very good. What would you say then, as we talked about these screenings, what are the barriers to screenings?
The screening colonoscopy.
Yeah.
I think the thing that I hear a lot from patients tends to be around the bowel prep. They don't want to drink a certain volume of a drink and then have a bunch of bowel movements that transition to diarrhea to clean out the colon, so that we have a good prep to find these small polyps. The other thing is usually around the anesthesia, whether that's moderate kind of sedation anesthesia or general anesthesia. The anesthesia risk alone is what people kind of, if they have other issues health-wise. And then the kind of other big thing that I would say, and 25%, I think we said, of patients will have a polyp on a colonoscopy. And the big thing that we always hear is that colonoscopies are not without risk, and the risk that's quoted is always the perforation, where if we perforate the colon during a colonoscopy, and that happens in a fraction of patients. I said like 0.2% maybe.
Wow. So we're going to talk about 25% have polyps, 0.2% perforations.
Right. You're more likely to have side effects or a complication from having the polyp or having a cancer than you are to the screening.
Yeah. So weigh the numbers. Yeah, it's pretty clear on paper, it seems.
We think so.
You think so? What else do we want to add? Dr. Smith, Dr. Kim, Dr. Pedersen?
I think just sort of he had touched on it, but I feel like this is such an exciting time. I mean, the last 3 to 5 years have felt so different with the advances and the just how agile we're able to be now with treating colorectal cancer. And from the surgical side of things, like really a very small subset of our patients, a very tiny fraction, will actually go to surgery and then need an ostomy. Permanently, of course. They might need a temporary bag, but that's a really small amount of patients. So the surgical technology is getting, great. We have non-operative management, short course radiation, and the things that we've talked about, immunotherapy and ctDNA, and I think that all of those things make it just such a really exciting time where, 20 years ago, your situation would have been, and even 5 years ago, your situation would have been treated completely differently. And that really makes me very hopeful for all of the progress that's going to come very shortly.
Yeah. Dr. Kim?
I would echo everything that's been said. I think really one of the important and exciting kind of new movements is this normalization of talking about cancer in patients younger than 50, this early onset, young onset. So recognize we're not immortal. Check your poop, get your colonoscopies, and then seek medical care. And even if you don't have insurance or a way to pay for it, or you think there's no hope, still talk to someone about it. There's resources, social work, financial assistance. There's always somebody there to help.
Great. Dr. Pedersen?
He took my line. I was going to say, check your poop. That really is important. Don't become my patient, so keep an eye on them.
Yeah, I mean, knowledge is power, right? I mean, that's where
Absolutely.
these screenings are so important.
Absolutely.
We have time for one more question. So, if a cancer patient has an infection, can they still receive chemo treatment?
I'll let Dr. Kim take, no.
Please don't.
So it's very dependent on the situation and very patient specific what the infection is, and some infections, yes, we can treat still with chemo and not make the infection worse, and other treatments we do have to pause for a little while and let it clear up, or not give the chemo in some cases.
Yeah, so it's a case-by-case
Right.
situation. I think there's one more question here. I think we have time for it. Is there any research indicating why there is an increase in young people with polyps? We've kind of talked about that, but they're asking specifically antibiotic use, anything else like that?
It's like they were listening.
Yeah. We were talking about this before.
Oh,
that
interesting.
started. Yeah, we were talking about all the
Interesting.
new risk factors, but yeah, it's such an area of evolution, and I
Yeah.
think that we don't really realize how many steps, our food, our shampoo, everything gets to where it gets to our doorstep. And I think that as we clarify a lot of that, all the things that we, inadvertently or intentionally put in our bodies, we hopefully will become more clear about these links. But there are, as she mentioned, a lot of things that you can do, a lot of modifiable risk factors to really decrease your risk. I don't know if you want to talk specifically about antibiotics, but.
Yeah, I was warned in the room earlier when we were chatting not to. So I'll try to be very cautious, because if someone has an infection and needs an antibiotic, I mean, take the antibiotic, absolutely. But there is some data, especially that's been coming up in the young onset literature, suggesting that the use of antibiotics might kill off some of our good bacteria and change the balance between the good and the bad bacteria that live in us. And what we're appreciating more and more is that these bacteria that live in us actually help regulate our immune system. And every single day of our lives, not to scare anybody, we develop cancer cells in our body, many cancer cells in our body each and every day that we live. And yet our immune systems are so effective, they find them right away. They kill them for the most part, as long as they can't hide. And some cells can hide, and that's why they become cancer. But so if you kind of kill off some of the good immune bolstering bacteria in your intestine, there has been some suggestion that you might be at a higher risk of developing intestinal cancers. I think that what's important, as I said, is don't avoid antibiotics if you truly need one. However, there are many cases where people get antibiotics where they don't need them.
Right.
And honestly, that's not on the patient, to determine when you do and do need one. Just go to the doctor if you think you have an infection. But on the doctor side of things, we have to be very judicious about who really needs antibiotic. For sinus trouble, do most people who get a Z-Pak need it? I'm going to make so many enemies, but no. No, just ride it out. Use your sinus rinse and move along. So it's kind of picking those moments. But again, don't worry about that. If you need an antibiotic, use it, but just really make sure that you need, that your doctor really justifies it.
Sure. Well, this has been very interesting. Thank you to all of you for taking your time tonight, explaining things in ways that were very easy to understand. And I think the takeaway is get your screenings, do the colonoscopies. It can save your life.
And see a doctor if things are not right.
Absolutely. Thank you.
Thank you.
Thank you.
And I want to obviously thank all of our panelists. We had a wonderful conversation tonight. Remember that in the future, we're going to have more of these. We want to thank you for all of your questions that you sent along. Meanwhile, we invite you to visit yourdiseaserisk.com to learn about your risk of 12 cancers and other chronic diseases and to get personalized tips for preventing them, which should be so incredibly helpful as you live your life. Our next Learning with National Leaders event will be late this summer on Wednesday, September 27th, and we'll be talking about the importance of clinical trials, which we discussed quite a bit today. As always, thanks for joining us, and we'll see you next time.